Welcome back to the Deep Dive. Today we're focusing on a really crucial area for pediatric nursing. We're diving into caring for kids with mobility issues, so neuromuscular and musculoskeletal disorders. It's all coming straight from Chapter 22 of Essentials of Pediatric Nursing.
Yeah, this chapter is absolutely fundamental for nursing students because, kids aren't just tiny adults. Their anatomy, their physiology, it's different. And understanding those differences is key. It helps with spotting problems early, preventing complications down the road, and really tailoring care, especially for chronic stuff.
Right, and it's a dense chapter. You've got A&P, specific diseases, tons of nursing actions. It's a lot. So our mission today is to kind of cut through that, give you the high-yield essentials. We'll walk through the key A&P points, common treatments, the nursing process, and some major disorders. Okay, let's unpack this. First things first, pediatric variations. We have to start with why kids are more vulnerable in some ways. What are the big differences in their nervous system and spine that increase injury risk?
Well, it starts super early, even before birth. That neural tube, which becomes the brain and spinal cord, it forms between 3 and 4 weeks gestation. Any disruption then, huge impact. And then mechanically, a child's neck, their cervical spine, is just way more mobile than an adult's. The ligaments are looser. So if there's trauma, that flexibility actually means a much higher risk for cervical injury.
And the whole system isn't quite online yet because the wiring, the myelinization, isn't complete. Can we simplify that? It's basically control follows the myelin.
That's a great way to put it, yeah. Myelinization isn't finished at birth. It wraps up around age 2, and it follows a really predictable path. Head to toe, so cephalocaudal, and center outward, proximal distal. That directly explains development milestones, right? Head control comes first. Then trunk stability. Then the fine motor stuff in the hands and feet. It literally maps onto where that nerve insulation is laid down.
Okay, moving to the bones. The chapter says pediatric bones often bend rather than break. How does that work?
It's about their makeup. They're less ossified, so less hardened bone, more flexible, lower mineral content. But a really big factor is the periosteum, that membrane covering the bone. It's super thick and strong in kids.
Like a built-in shock absorber.
Kind of, yeah. It helps contain the force. So instead of a clean snap, you often get those incomplete fractures, the green stick where it breaks on one side but just bends on the other, or a buckle fracture where it just kind of crunches, very common in kids.
But there's a weak spot in this flexible system. The growth plate.
Exactly. The growth plate, or the physis, it's cartilage, not hard bone yet, so it's structurally weaker. This is where the long bones grow from, so injury there. And we use the Salter-Harris system to classify those. The big worry isn't just the break itself. It's that damaging the growth plate could stop growth prematurely. That can lead to, deformity or one leg ending up shorter than the other, serious long-term consequences.
Okay, so that's trauma risk. But what about things that look concerning but are actually just normal development, things parents or new nurses might worry about?
Oh, definitely. There are a few classic ones. You see spinal curves develop naturally. First, the fetal curve, kyphosis. Then when they start holding their head up, they get that cervical lordosis, the neck curve. And the really obvious one is the toddler lordosis, that sway-backed potbelly like toddlers have.
Right.
Looks dramatic, but it's normal. Usually goes away as their abs get stronger.
And their legs go through phases too, don't they?
They really do. Initially, many babies and toddlers are bow-legged genu varum, often with some in-toeing too, internal tibial torsion. That usually sorts itself out by age 2 or 3. Then it's common for them to temporarily become knock-kneed genu valgum. That phase usually resolves by age 7 or 8, so quite a bit of change is normal.
Okay, so we know the vulnerabilities and the normal variations. When things do go wrong and need intervention, what are the main tools for immobilization? Casts, traction, external fixation.
Right. Casts are pretty common, obviously, for setting fractures, keeping things aligned, reducing pain. One neat thing mentioned is Gore-Tex liners. Makes the cast waterproof, which is, huge plus for kids and families. Still needs care, but better than the old plaster casts.
And traction seems like there are different kinds. What's the key distinction nurses need to grasp?
The main difference is skin versus skeletal. Skin traction uses things like boots or straps attached to the skin. It's for less force, shorter periods. Skeletal traction, that's pins or wires drilled right into the bone, allows for much more pulling force, used for longer durations, often in more complex situations like with balanced suspension setups.
Got it. And then external fixation, those frames on the outside with pins going in, what's the absolute #1 nursing priority there?
Pin care, without a doubt. Whether the doc wants saline or chlorhexidine, you have to be meticulous. Check those sites constantly for any sign of infection, redness, drainage, increased pain. You are literally guarding the bone from bacteria.
And regardless of how they're immobilized, cast, traction, fixator, there's one assessment that's constant: the neurovascular check.
Absolutely essential. It's your baseline and your ongoing monitor. You're doing these checks frequently, like at least every 4 hours. If a child's in traction, you're looking at color. Is it pale, bluish? You check movement. Can they wiggle toes or fingers? Sensation, any numbness or tingling? Also edema, swelling. And pulses, are they strong? Equal. Capillary refill time too, the whole package.
Okay, let's hit pause there. Clinical reasoning alert time. What's the absolute worst finding during that neurovascular check, the one that means emergency?
That has to be signs of compartment syndrome. This is when swelling inside a muscle compartment gets so bad it cuts off circulation. It's an orthopedic emergency. The classic sign, the big red flag, is pain that is way out of proportion to the injury, like excruciating pain. And specifically, pain when you passively move their fingers or toes. If you see that, plus maybe pallor or weak pulses,
Yeah.
you need to act immediately. Waiting can mean losing limb function.
Crucial point. Okay, shifting gears slightly. For kids with chronic neuromuscular conditions, like CP, what meds are key for managing spasticity?
Two main ones come up. Baclofen is a big one. It's a muscle relaxant that works centrally. Can be oral, or for severe cases, given through an intrathecal pump directly into the spinal fluid. And for more localized spasticity, like in specific muscle groups causing tightness or contractures, botulinum toxin injections are used. It blocks the nerve signal to that muscle temporarily.
All right, here's where it gets really interesting. Let's dive into some specific disorders, starting with neural tube defects, especially myelomeningocele.
Right, the most severe form. This is where the spinal cord, the meninges, the nerves actually protrude out through a defect in the vertebrae. The level of the defect determines the neurological deficit, obviously, but what's really important for nurses are the associated issues. Hydrocephalus, excess fluid on the brain, is incredibly common. Like 80% of these kids develop it.
And why is hydrocephalus so common with myelomeningocele?
It's usually due to something called a type 2 Chiari malformation. Basically, parts of the brainstem get pulled down into the spinal canal, and that physical displacement blocks the normal flow of cerebrospinal fluid, causing it to back up and build pressure, hence the hydrocephalus.
So a baby's born with this exposed sac. What are the absolute immediate nursing priorities pre-op?
It's all about protecting that sac. Goal number one is prevent rupture and infection before surgery can happen. So you cover it immediately with sterile, saline-soaked, non-adhesive gauze. Keep it moist. The baby has to be position prone, lying on their belly, and you've got to be vigilant about keeping urine and stool away from the sac. Meticulous care. And don't forget the latex allergy risk. It's huge in these kids because of all the surgeries, the catheters.
Right, constant exposure.
Exactly. So strict latex-free environment from day one is critical.
Okay, next up, developmental dysplasia of the hip, DDH. Talk us through the key assessment maneuvers.
Sure. Risk factors include being female, breech birth, and those maternal hormones making ligaments lax. The two main tests are the Barlow and the Ortolani. They're done gently on newborns and young infants. Think of Barlow as trying to provoke dislocation. You adduct the hip, bring the thigh towards the midline, and apply gentle downward pressure. You might feel a slip if it's unstable. Ortolani is the opposite. You're trying to reduce a dislocated hip. You abduct the thighs, move them outwards, and apply gentle upward pressure. A positive sign is feeling or hearing a clunk as the femoral head slips back into the socket.
And if DDH is diagnosed in an infant under 6 months, what's the go-to treatment?
Usually the Pavlik harness. It's a soft harness that holds the baby's hips in flexion and abduction, kind of a frog leg position. This keeps the ball part of the hip joint, the femoral head, pressed nicely into the socket, the acetabulum allowing the socket to develop properly around it. Key nursing teaching is about continuous wear, often 23 hours a day, and checking the skin carefully under the straps for any irritation.
Let's touch on osteogenesis imperfecta, OI, or brittle bone disease. It's a collagen defect, right?
Exactly. It's a genetic disorder affecting type 1 collagen, which is like the main protein scaffolding for bone. Without good collagen, bones are weak, low mass, and fracture incredibly easily, sometimes with minimal or no apparent trauma. Other signs can include blue or grayish sclera, the whites of the eyes, though that's not always present or specific. Problems with teeth too, dentinogenesis imperfecta. But the absolute critical nursing piece, highlighted in the text teaching guidelines, is safe handling.
How so?
You have to be extremely gentle, never push or pull on limbs, never lift the baby under the armpits, always support the head and trunk fully, lift by sliding a hand under the buttocks and legs, another supporting the head, shoulders, and back. Minimize any stress on the bones.
Okay, and cerebral palsy, CP. The most common motor disorder. How do we break down the types?
Yeah, CP isn't one single thing. It's an umbrella term for non-progressive problems with motor control caused by brain damage or abnormal development, usually happening before birth. It ranges hugely from maybe a mild limp to severe impairment. The most common type is spastic CP. Think hypertonicity, stiff muscles, exaggerated reflexes. Then there's dyskinetic or athetoid CP, characterized by uncontrolled, writhing, or jerky movements. And ataxic CP involves problems with balance and coordination. Management is all about maximizing function. Multidisciplinary team approach PT, OT, speech. Meds like baclofen for spasticity. And often, orthotics like AFOs.
Ankle-foot orthotics.
Right, AFOs, to help stabilize the ankle, prevent contractures, improve walking efficiency.
Moving into acquired issues, especially in older kids and teens, slip capital femoral epiphysis, SCFE. Sounds serious.
It is. SCFE happens when the top part of the femur, the ball part, actually slips off the neck of the bone right at the growth plate. It typically occurs during the adolescent growth spurt. And a major risk factor is obesity. The extra weight puts more stress on that vulnerable growth plate.
And there's a massive nursing alert here. If you suspect SCFE, what must you not do?
Do not attempt passive range of motion on that hip. Ever. Because forcing movement can make the slip worse. It can actually shear off the blood vessels supplying the femoral head, leading to a vascular necrosis, bone death. So, if an adolescent, especially an overweight one, complains of hip, groin, or even knee pain, it can be referred. Suspect SCFE. Put them on immediate bed rest. No weight bearing. They need urgent orthopedic consult for surgical pinning to stabilize it.
Okay, duly noted. What about scoliosis, the spinal curve?
Right, a lateral or sideways curve of the spine, more than 10 degrees. Most cases are adolescent idiopathic, meaning we don't know the exact cause. Treatment depends on how severe the curve is. Small curves, usually just observation, regular x-rays to monitor progression. Moderate curves, say 25 to 45 degrees, often require bracing. And the big challenge there is compliance. Kids often need to wear the brace 18, even 23 hours a day. That's tough socially and physically. Right. Severe curves, generally over 45 degrees, usually need surgery, spinal fusion with rods to correct and stabilize the spine. And post-op, a key nursing skill is log rolling, turning the patient as a single unit, keeping the spine straight, no twisting, to protect that fusion.
We talked about how resilient kids' bones are, but when should a fracture make you think about non-accidental trauma, about abuse?
Yeah, even with flexible bones, certain fracture patterns are red flags, especially in very young children. Spiral fractures of the femur, the thigh bone, in an infant who isn't walking yet, highly suspicious. Any rib fractures in a child under 2 are also very concerning. These types of injuries often require significant force that doesn't fit with a simple fall or bump, needs careful evaluation.
Lastly, just briefly, overuse injuries in young athletes, sprains and syndromes.
Right. For acute sprains, the standard advice we give families is RICE-A. Rest, ice, compression, elevation. That's the cornerstone of initial management. Then you have overuse syndromes like Osgood-Schlatter disease, that painful bump below the knee where the patellar tendon pulls on the tibia. Common and active, growing kids. Prevention advice really focuses on not doing too much too soon. Limiting increases in training intensity or duration, like no more than 10% per week. Making sure they get rest days. Avoiding specializing in just one sport too early. Let those growing tissues recover. So what does this all mean? If there's one big takeaway from everything in this chapter, it's that solid pediatric nursing for mobility and neuro issues comes down to truly understanding those developmental differences, from how myelin lays down and dictates motor skills to where that vulnerable growth plate sits. Knowing this stuff lets you anticipate risks, plan effective care, and involve the family properly.
Yeah, it really underscores how different caring for kids is. And, we covered a lot of the physical stuff, the surgeries, the braces, the assessments. But the chapter also brings up the nursing diagnosis of chronic sorrow for families dealing with lifelong conditions. So maybe a final thought for listeners. Beyond the physical care for something like myelomeningocele or muscular dystrophy, what are those crucial nursing interventions that address the long-term emotional journey for the child and the family? Something to really think about.
That's a really important point. It reminds us there's always a person, a family, behind the diagnosis.
Absolutely. Well, we packed a lot into this deep dive. Huge thanks for joining us and walking through this complex material.
My pleasure. Until next time.